So in the previous page, we have studied about the how the structures of the brain and the spinal cord are formed, and from now we will discuss that what will happen if there is some deformity or any kind of defect. So this is the neural tube defect. Failure of neural tube to close completely by week 4 of development, associated with maternal folate deficiency during pregnancy. Diagnosis: it will diagnose by ultrasound and maternal serum alpha fetoproteins, and it will increase in open neural tube defect. Spinal dysraphism, spina bifida occulta. This will have four types: the spina bifida occulta, meningocele, myelomeningocele, or myeloschisis. So here is the spina bifida occulta, closed neural tube defect. This is the closed neural tube defect. Others are the open neural tube defects. So what is this? It is the failure of caudal neural tube to close, but no herniation. Dura is intact. Dura means the upper meninges are intact, usually seen at lower vertebral levels, associated with tuft of hair or skin dimple at the level of bony defect. So here are some the diagnosis things which you can see that it is in the lower vertebral level, and there may be some tuft of hair or skin dimple at that level, and it is a closed neural tube defect. Meningocele, it is an open neural tube defect meninges, but not the neural tissue herniate. In this, meninges herniate outward through the bony defect. Meningomyelocele, this is the open neural tube defect, meninges and neural tissue. Two things. In previous, there was only meninges, and here there are meninges and the neural tube. And the main portion which herniate is the cauda equina, herniate through the bony defect. Myeloschisis, it is also an open neural tube defect. It is exposed, unfused neural tissue without skin or meningeal covering. It is the only the neural tissue. So we can repeat it. It is the closed neural tube defect, spina bifida occulta. Occult, say you from occult you can remember that it is occulta mean closed, and it is a failure of caudal neural tube to close. There is no herniation, and dura are intact. It is on the lower vertebral side and associated with the tuft of hair. Meningocele, it is the open neural tube defect, only meninges herniate. Meningomyelocele, it is the open neural tube defect, meninges and neural tissue both herniate, and myeloschisis, only the neural tissue herniate. So the next part is the cranial dysraphism, anencephaly. Anen, you can remember from here that it is showing some kind of absence. It is open neural tube defect, failure of rostral. Other is the caudal, and opposite to it is the rostral from our uh, head side. Failure of rostral neuropore to close. No forebrain open calvarium often presents with polyhydramnios, decreased fetal swallowing due to lack of neural control. So here you can see that there is no forebrain, as it is anencephaly, no forebrain, open calvarium, the skull is open, and it often shows polyhydramnios. Uh, from here you can see that the spina bifida and these things are shown in the picture, It is normal, everything is closed, there is no herniation. This is the vertebra, and above is the skin. Spina bifida occulta, there is tuft of hair. It may be present or absent, as you can see here, it is written already. And there is something defect, but there is no herniation. And meningomyelocele, it is the open neurotube defect, and you can see here that meninges herniate. So there are only meninges which herniate, and in meningomyelocele, both meninges and the neural tissue is herniating here. This is the next portion is the brain malformation, and what would these look like? It is the often incompatible with postnatal life. Survivors may be profoundly disabled. So it is incompatible with life, and if by any chance a fetus survive, it will be profoundly disabled. Holoprosencephaly. So here we see what is this? Failure of forebrain to divide into two cerebral hemispheres. So by this we can understand that there would be no any differentiation. There would be no any cerebral hemisphere, but only the forebrain as a single structure. So what is this? The developmental field defect usually occurring at weeks 3 to 4 of development. You should have to remember it that it is the week 4, 3 to 4 of development associated with SSH mutation. This could be a gene which will mutate and will result in this abnormality. So may be seen in Pitou syndrome, trisomy 13. You can collect it from the previous knowledge that the Pitou syndrome is the trisomy 13, and it may be called as fetal alcohol syndrome, which may be due to the mother which will consume alcohol during the pregnancy. It presents with midline defect, monoventricle. Mono means there would be a single ventricle, fused basal ganglia. Basal ganglia will also be fused, and it will be associated with the cleft lip or palate. Hypotelorism, cyclopia, proboscis. There would be increased risk of pituitary dysfunction, and which will result in diabetes insipidus. The second category is the lysencephalon, failure of neuronal migration. The neuronal cells will not migrate, and the abnormality will occur. It would be called as lysencephaly. It is smooth brain surface that lacks sulci and gyri. So it means that there would be smooth structure of brain and no sulci and gyri, which we can see here as, and this is the gyri and this is the sulci. It presents with dysphagia, seizures, microcephaly, and facial abnormality. So this may help in diagnosis. Yeah, you should have to remember these some four associated things. Here we go on the next page that this is the posterior fossa abnormalities or malformations. Posterior fossa, as we know, it contains cerebellum and hindbrain structures. So it is related to these structures, and the first portion is called Chiari-1 malformation. Chiari-1 malformation, what is this? This is downward displacement of cerebellar tonsils through foramen magnum. If we go to the anatomy, we can see that there is a foramen, a very big foramen, from which the medulla or may sometimes herniate, or which connects the spinal cord and the brain. This is the foramen magnum, one structure. So structure one, which would herniate in the Chiari-1 malformation, it is the cerebellar tonsils. It is highlighted here, cerebellar tonsils. It is usually asymptomatic in childhood, manifests in adults with headache and cerebellar symptoms. You may be remember that cerebellar symptoms will relate to the positions and associated with spinal cord cavitation, syringomyelia. There would be spinal cord cavitation, syringomyelia. You should keep it in mind. So the Chiari-2 malformation. What is the Chiari-2 malformation? It is the downward displacement of the cerebellum. Here is only the cerebellar tonsils and here is the cerebellum. When vermis and the tonsil, both things, vermis and the tonsil and the medulla, two structure will herniate, the cerebellum and the medulla, through foramen magnum. It is non-communicating hydrocephalus, more severe than Chiari-1, usually present early in life. Here we can see that it is asymptomatic in childhood, but it presents early in life with dysphagia, stridor, and apnea, limb weakness, and associated with myelomenincocele, usually lumbosacral myelomenincocele. The third disease is the Dandy-Walker syndrome. What is this? It is agenesis of cerebellar vermis. In this, cerebellar vermis are not developed, and it results in cystic enlargement of the ventricle, fourth ventricle, and we can see as a arrow in this. It is the very large fourth ventricle, and that fills the enlarged posterior fossa. The posterior fossa is filled with this fourth ventricle, associated with non-communicating hydrocephalus and spina bifida. The other thing we will discuss is syringomyelia. What is this? It is fluid-filled gliosis-lined cavity within spinal cord. It's a fluid-filled cavity in the spinal cord. Yellow arrow in picture A. Yes, this is the yellow arrow in picture A, and this we can see that a cavity which is fluid-filled. Fibers crossing in anterior wide commissure spinothalamic tract are typically damaged first. So what happens here is the anterior wide commissure is damaged. What is the anterior wide commissure having? It is the spinothalamic tract. So here is the cape-like loss of pain and temperature sensation in the bilateral upper extremities. What is cape-like? Cape-like thing we can remember it by an example that if you are covering your back or upper trunk, half of upper trunk and arms with a shawl, and this shawl will cover your upper trunk and the arms. This is the cape area, which will have the symptoms like loss of pain and temperature sensation. As lesion expands, it may damage anterior horn. It may also damage anterior horn if it expands, which will result in lower motor neuron deficit. Here is something syrinx. It is a Greek word which means tube, as in the syringes. So yes, syringe have a tube. And syringomyelia, mylia means spinal cord, and syringo means cavity. That is the cavity in the spinal cord which is fluid filled. Most lesions occur between C2 and T9. C2 and T9 is the area where there will be abnormality, usually associated with Chiari-1 malformation. Chiari-1 malformation, see if Chiari-1, and this is the syringomyelia. Yes, exactly. He's right. So two things have we have discussed that the location is C2 to T9, and it is associated with Chiari-1 malformation, and less commonly associated with other malformation, infections, tumors, or trauma. And we have also discussed this picture. is the development of tongue. This looks like our tongue. Yeah, the first pharyngeal arch forms anterior two-third of tongue. This is the anterior two-third of tongue, and this is absolutely developed from the first pharyngeal arch. Sensation via cranial nerve 3, taste via cranial nerve 7, the facial nerve, and the third and fourth pharyngeal arches form posterior one-third. This is posterior one-third of the tongue. Sensation and taste mainly via cranial nerve 9. Extreme posterior. This is the extreme posterior, I think, and this have a neural supply by the cranial nerve 10. Motor innervation is via cranial nerve 7 to hyoglossus, retract and depresses the tongue. So depression and retraction of tongue is caused by the cranial nerve 7. And the muscles which are involved are the genioglossus, which protrude the tongue, and styloglossus, which draw sides of tongue upward to create a trough of swallowing. And the motor innervation is via cranial nerve 10 to palatoglossus, which elevate the posterior tongue during swallowing. So here are some cranial nerves which have the sensory and the motor supply. Here is the summary. The taste, which is the major part of major portion or major function of our tongue, it is supplied by the cranial nerve 7, 9 and 10, which have a brain portion, nucleus tractus solitarius. Pain, which is supplied by the cranial nerve 3, 9 and 10. Motor, which have a supply from cranial nerve 10 and 12. The genie, this highlighted genie, which sometimes belong to our structure tongue, comes out of the lamp in style. See, there is nothing to know about it. Cranial nerve 10 innervate the palatal glossus. So this is some mnemonic 10 from the 10 palatal glossus, and palatal glossus belongs to this muscle, which will do the thing that it will do, elevate posterior tongue during swallowing. Neurology. Now the embryology have been finished from here, and now we will start the anatomy and physiology. What is the basic unit of CNS? Basic unit. Uh, as we have a basic unit of life is cell. Basic unit of CNS is the neuron. Neuron, single transmitting cell of nervous system. It is a permanent cell. Permanent cell means it cannot divide. Yes, do not divide in adulthood. Signal relaying cells with dendrites. It is a signal relaying cell. Signal relaying cell means it sends signal from effector to three structures. We have effectors and other thing, receivers. Yes, receivers. Signal relaying cells with dendrites receiving input. Cell bodies have cell bodies and axon which send output. Cell bodies and the dendrites can be seen on nasal stains, RER. RE, what is RER? RER is not present in the axon. Neurons marker neurofilament protein, synaptophyte. RER is not present in the axon. Neuron, it is a neuronal marker, I think. Neurofilament protein or synaptophysin. Yes, I will discuss these points in the next video. So keep in touch with me. The second structure is the astrocyte, which support the neuron. Neuron is the basic structure. Other cells support the neuron. Largest and the most abundant glial cell in the CNS. Physical support, yes, I discussed. It gives physical support to the neuron. It repairs the neuron. Removal of excess neurotransmitter. Component of blood-brain barrier. Glycogen fuel reserve buffer. Reactive gliosis in response to neuronal injury. These are some functions that astrocytes have. It is derived from the neuroectoderm. Here is some kind of factor, derived factor, I think, which will help in the derivation or the differentiation of the astrocytes. So the other thing we will discuss is the microglia, and we have studied it previously that the macrophages in the brain are called microglia. So what it is? It is phagocytic scavenger cells of the CNS. Activation in response to tissue damage, release of inflammatory mediators, e.g. nitric oxide, glutamate, not readily discernible by nasal stains. So it is derived from the mesoderm. HIV infection infected microglia fuse to form multinucleated giant cells in the CNS in HIV associated dementia. So here is something which is looks like hide. The other thing is the ependymal cells. Ciliated simple columnar glial cells lining ventricles and central canal of spinal cord. Apical surfaces are covered with the cilia, which circulate CSF, and microvilli, which help with the CSF absorption. So it is derived from the neuroectoderm, specialized ependymal cells, which are called choroid plexus. These produce CSF. And this is also high yield. You should remember this. So here's the next thing we will go here as what is the myelin? Myelin, it increases the conduction velocity of signals transmitted down the axon. Saltatory conduction of action potential at nodes of firmware where there are high concentration of sodium channels. You should you know already something about the node of Renware and the saltatory conduction of the action potential and the myelin sheath. The next thing is in the CNS, including cranial nerve 2, the myelin is synthesized by oligodendrocytes. In peripheral nervous system, myelin is synthesized by the Schwann cells. So you should remember these two things. CNS, myelin is produced by oligodendrocytes, and in PNS, including cranial nerve 3 to 12, myelin is produced by Schwann cells. Myelin wraps and insulates axons. Uh, Myelin it lacks the main structure of axon. It decreases the membrane capacitance, increases membrane resistance, increase space constant, and decrease time constant. So here are some constants and the complicated things. CNS, you can remember here the CNS and oligodendrocytes and the PNS Schwann cells. So COPS, CNS oligodendrocytes, PNS Schwann cells. What are Schwann cells? Here we can say that this is a nucleus and this is the Schwann cell and the myelin sheath which look like wrap, and the distance between the two Schwann cells is the node, which is the node of Frenier. It promotes axonal regeneration derived from the neural crust cells. So you should remember it, derived from the neural crust cells. So each Schwann cell myelinates only one PNS axon. ठीक है? Okay. Injured in Guillain-Barré syndrome. Schwann cells marker. Schwann cell marker is the S100. So you should keep in mind three things. Three things. You can see here three things. One is that Schwann cell myelinates only one PNS. मतलब peripheral means PNS axon. Second is the that it is injured in Guillain-Barré syndrome, and the third is the Schwann cell marker is the S100. What is the oligodendrocyte? Oligo, as we remember that it belongs to CNS, myelinates axon of neurons in the CNS. Each oligodendrocyte can myelinate many axons. Here, each Schwann cell only myelinate one axon in PNS, but the oligodendrocyte myelinate many axons, almost 30. Predominant type of glial cells in the white matter. It is the predominant type of glial cells in the white matter. Derived from the neuroectoderm, fried egg appearance. It is fried egg appearance. We can say this gray structure is the you can say as our yolk plus the albumin protein, and it look like the fried egg on the frying pan. Fried egg appearance histologically. Injured in multiple sclerosis. It is injured in Guillain-Barré syndrome. Schwann cell is injured in Guillain-Barré syndrome, and the oligodendrocyte is injured in multiple sclerosis, and the progressive multifocal leukoencephalopathy and leukodystrophies. These are the three structures which belong to oligodendrocyte and its damage. We go next, and now it is the action potential. So action potential, mainly the resting membrane potential, we can say is the minus 27 is the resting membrane potential, and as number one we can hear at the voltage gated sodium channel open, and these will move in the neuronal cell, and the negative charge will become more positive and less negative, and the action potential or the curve will go upward, and as it reaches the minus 55, or you can say the threshold reaches the minus 45, and it goes upward more. As it reaches the 40 plus 40, the membrane action potential will occur. Depolarization will start. We should first of all read the text, then we will discuss this graph. Resting membrane potential. Membrane is more permeable to sodium. At resting membrane potential, membrane is more permeable to this potassium than sodium at rest. Voltage gated sodium and potassium channel are closed. What will happen if membrane depolarize? the sodium activation gates open and sodium flow inward. As the sodium flows inward, there would be more positive inward, and the membrane repolarization. Sodium inactivation gates close at peak potential, thus stopping the sodium channel inflow. Potassium activation gates open and potassium flows outward. As the potassium flows outward, there will be restoration of the more negative ions inward and the repolarization starts. Membrane hyperpolarization. Potassium activation gates are slow to close. Excess potassium efflux and brief period of hyperpolarization. Voltage gated sodium channels switch back to resting state. Sodium and potassium pump restores ion concentration. So we try to understand all this text with this diagram. At number 1, this is the resting potential, resting membrane potential. At resting membrane potential, what is going on in the cell? You can see here that the sodium channel are closed and the potassium channel are closed, and the inward potential is the action potential is the minus 75. Voltage is the minus 75. At depolarization, which is the stage 2, what will happen? You can see here that the sodium channels are open and the potassium channels are closed. So the potassium is going inward and there is more positive inward. As there is more positive inward, the depolarization going on and the curve is going upward about the more positive towards the more positive. At stage 3, which is after the depolarization, comes the repolarization. In repolarization, the sodium channel will close, potassium channel will open. Potassium channel, in this potassium is going outward and the more positive is going outward, and as the positive is going outward, you can see here that this curve is going downward. So stage 4, this is membrane hyperpolarization. So what is hyperpolarization? It is written that the potassium channels are very slow to close. As these are very slow to close, what would happen? These potassium channels will keep open and the potassium will keep moving outward, and there would be more negative inward, even more than the 75%, and the curve is going below the baseline. Okay, so here are some basic things you should understand about the neuronal action potential. So there are some sensory receptors of the nervous system we will see here as the free nerve endings. Free nerve endings. Nerve endings mean these are the endings of nerves which which may be on our the peripheral sides, our skin, our fingertips. These nerve endings will end in our fingertips or our skin. So there are few types. It is the A gamma, A gamma. These are the fast or myelinated fibers. As these are the myelinated fibers, so these will be fast. These are the unlimited C fibers, are the unlimited fibers, so these are slow. A delta plane is these are fast, but the C is slow. Okay, A delta plane is fast. So this is A is delta. So this is not gamma. This is delta. A delta is fast. C is slow. So location. Where are these free nerve endings present? All tissues except cartilage and islands. Numerous in skin. So these are more in skin. These are present in all tissues except cartilage and islands, but these are more present in the skin. What these free nerve endings will carry? These will carry pain and temperature. The second are the Meissner corpuscles. These are large myelinated fibers. Myelinated so means these are fast and adapt quickly. Glabrous skins. Glabrous means these are present at the sides of skin which are hairless. These will carry dynamics, means different kind of sensations like fine, light, touch, low frequency vibrations, skin indentations, mean skin pressures. Pacinian corpuscles, these are large myelinated fibers, adapt quickly, same as the previous. And these are the deep skin present in the deep skin layers like ligaments and joints. These carry high frequency vibrations and pressures. Merkel discs, large, myelinated, and these also no, not also. These adapt slowly. And this is the difference from the previous. Meissner corpuscles adapt quickly. Pacinian corpuscles adapt quickly, but discs adapt slowly. These are present at fingertips and superficial skins. Superficial skin, and these carry pressure, deep, static touch, shape, or edges. Ruffini corpuscles. So these Ruffini corpuscles, these are large myelinated fibers intertwined among collagen fiber bundles. Adapt slowly. These adapt slowly. So within all these sensory receptors, only two receptors adapt quickly. These are Meissner corpuscles and Pacinian corpuscles. All other fibers adapt slowly. These Ruffini corpuscles are found in the fingertips. Which other receptors are found in the fingertips? Yes, these are Merkel discs. And these are also found in joints. So, what are their specialties? These cells stretch and joint angle changes. So, the next thing is peripheral nerve. What is peripheral nerve? Nerve which is found in the peripheral nervous system. This is the peripheral nerve. These have three layers. The endoneurium, which is you can see here. This is the endoneurium nerve fibers, which it is around the nerve fibers. It is very thin, supportive, connective tissue that unsheath and support individual myelinated nerve fiber. Individual myelinated nerve fiber uh, may be affected in Guillain-Barré syndrome. So this thing is to remember that it may be affected in Guillain-Barré syndrome. The other layer is the perineurium. Perineurium, you can see here. This surround a fascicle of nerve fiber. This surround a fascicle. The whole nerve fibers are surrounded by the perineurium. Endoneurium, that this single fiber. Endoneurium, this single fiber, and the whole fibers are surrounded by the perineurium. There is a blood nerve permeability barrier. Uh, you can relate it to the perineurium, and the other layer is the endoneurium. Endoneurium is a dense connective tissue that surrounds the entire nerve, epineurium, entire nerve. This contains fascicles and the blood vessels. Here are some mnemonic types of things. The endo means the inner, the peri means the around, and the epi means the outer. What is chromatolysis? Chromato means something which is colored, and the lysis is the breakdown. What is this? This is the reaction of neuronal cell body to axonal injuries. Reaction to neuronal cell body to axonal injury. Changes reflect increased protein synthesis in effort to repair the damaged axon. So basically, when an axonal injury occurs, there is some neuronal response to this injury which is called chromatolysis. It is characterized by round cellular swelling. There would be swelling, displacement of nucleus to the periphery, maybe some kind of protective mechanism that it will not be shown in the center, it will be shifted to the periphery. Sorry. And the third is the dispersion of the nasal substance throughout the cytoplasm. Dispersion of the nasal substance throughout the cytoplasm. And the Valerian degeneration. What is the Valerian degeneration? It is the disintegration of axon and myelin sheath distal to the site of axonal injury with macrophages removing the debris. So, if there is any damage to this site of damage, and this showing the distal portion, this is the proximal, which is toward the cell body. So here is the degeneration, which is called Valerian degeneration. Microglia infiltration, as we discussed previously, that the macrophages in the CNS are called microglia. And proximal to injury, what is proximal? This is the portion as the proximal. The proximal to injury, the axon retract, the cell body sprout new protrusion that grows toward other neurons for potential reinnervation, serves as a preparation for axonal regeneration and functional recovery. There would be some recovery changes that will lead to these functions proximal to the damage. So these are the three structures, three characteristics which we discussed here. This is the round cellular swelling and the displacement of nucleus to the periphery, and the dispersion of the nasal substances is these here. What is next? Yeah, we can subcategorize it. This is the chromatolysis, which is swelling and characterized by these three phenomena, and this is the axonal retraction, which is proximal to the injury, and the distal to the injury is the Valerian degeneration. The next thing is the neurotransmitter changes with the disease. So these are some neurotransmitters which are present in the CNS and the PNS. So acetylcholine, where it is located and where it is synthesized. This is the location of synthesis. This is formed in the basal nucleus of minor forebrain. It is located in the forebrain. Here it is synthesized, and it decreases in Alzheimer's disease, okay, and Huntington disease, and Parkinson disease. It is increased, and from increased we can relate it to the overexcitation, which is the main pathophysiology of the Parkinson's disease. Dopamine, it is synthesized in the ventral tegmentum, midbrain. It is decreased in depression, as dopamine is our motivation neurotransmitter. So when it is decreased, we are depressed, and when we are over motivated, as in schizophrenia, it is increased in schizophrenia, it is increased in Huntington disease, and again it is decreased in Parkinson's disease. GABA. GABA is our inhibitory neurotransmitter, and it is synthesized in the nucleus accumbens basal ganglion, which is the inhibitory area of the brain. It is decreased in anxiety and decreased in Huntington disease. Norepinephrine, it is our excitatory neurotransmitter. It is synthesized in the locus ceruleus, which is located in the pons. It is increased in anxiety. It is decreased in depression. Serotonin. Serotonin is also our happy hormone or happy neurotransmitter. So it is synthesized in the raphe nuclei, which is the part of brainstem, and it is decreased in anxiety. As in anxiety, we are depressed and we are not happy, so it is decreased. And in this Parkinson's disease, we are also deficient of serotonin. So the next page is related to the meninges. Meninges, these are the coverings around the our brain and the spinal cord. These are three membranes that surround and protect the brain and the spinal cord, derived from both the neural crust cells and the mesoderm. Remember it that it is derived from the neural crust cells and the mesoderm. So these are the three layers: the dura mater, the arachnoid matter, and the pia mater or pia mater. Dura mater. It is a thick outer layer closest to the skull. It is derived from both the neural crust cells and the mesoderm. The dura mater, it is the thick outer layer closest to the skull. Arachnoid matter, it is the middle layer and contains web-like connections. And the pia mater or pia mater, it is the thin fibrous inner layer that firmly adheres to the brain and spinal cord. CSF flows in the subarachnoid space located between the arachnoid and the pia mater. Epidural space which is above the dura. It is the potential space between the dura mater and the skull vertebral columns containing fat and the blood vessels. It is a site of blood collection associated with middle meningeal artery injury. The next thing and very much important in this section is the blood-brain barrier. The main function is it prevents circulating blood substances, e.g. bacteria and drugs from reaching the CSF, CNS. It is formed by four structures. Now listen very carefully. It is formed by four structures: tight junctions, basement membranes, pericytes, astrocyte food process. We discussed previously that astrocyte is involved in the blood-brain barrier. So again, tight junctions, basement membrane, and pericytes and astrocyte food processes. So it allows glucose and amino acids slowly by carrier mediated transport channels or mechanism to enter the brain area. A non-polar lipid soluble substance cross rapidly via diffusion. Now what is this? Circumventricular organ with fenestrated capillaries and no blood-brain barrier allow molecule in blood to affect brain functions. Area postrema. Here it is discussing some of the circumventricular organs of brain which do not have any blood-brain barrier. Number one, area postrema. It is the vomiting center after chemotherapy. OVLT, organum vasculosum lamina terminalis. It is an osmoreceptor, or the next thing is the neurosecretory product to enter the circulation. Neurophysis, ADH release. Blood brain barrier disruption. What happen if this barrier is disrupted, e.g. in stroke? It is vasogenic edema. The brain will become edematous. Hyperosmolar agents can disrupt the brain barrier. It increase permeability of the medication. The medication which is not previously was permeable to the brain is now have increased permeability for entering the blood-brain barrier. Vomiting center. What is the vomiting center? Coordinated by NTS in the medulla. Coordinated by neurotransmitters in the medulla, which receive information from the chemoreceptor trigger zone, located within the area postrema, pronounced pew pewstrema. Oh, it's not postrema, it's pewstrema. Area pewstrema in the fourth ventricle. GI tract via the vagus nerve, vestibular system, and CNS. So, mm, so what is a vomiting center receive information from the GI tract via the vagus nerve, vestibular system, and CNS itself. Chemoreceptor trigger zone and adjacent vomiting center nuclei receive input through five major receptors. So here is the thing: five major receptor which will mm, give input to the chemoreceptor trigger zone and the vomiting center: histamine, muscarinic, neurokinin, dopamine, and serotonin. Serotonin and dopamine and neurokinin antagonists treat chemotherapy induced vomiting. Treat chemotherapy induced vomiting. So you can see that when we give histamine, dopamine, and neurokinin inhibitors or antagonists, this will help treating chemotherapy induced vomiting. Now, histamine and muscarinic receptors. So this is not histamine, this is serotonin. Histamine and muscarinic antagonists treat motion sickness, and histamine antagonists only treat hyperemesis gravidarum. Hyperemesis gravidarum, which is commonly a symptom of first trimester pregnancy. So we can give histamine to these patients. Histamine antagonist, not histamine antagonist. The next thing is the sleep physiology. What is the physiology behind sleep? Very important thing, sleep. You may have very good relation with this sleep. So what is sleep physiology? What is the physiology behind sleep? Sleep is a cycle. Yes, it is a part of our circadian rhythm or cycle, and it is regulated by circadian rhythm, which is derived by the suprachiasmatic nucleus of the hypothalamus. It is driven by suprachiasmatic nucleus. Yes. Circadian rhythm control nocturnal release of ACTH, prolactin, melatonin, and norepinephrine. So the mechanism start when the suprachiasmatic nucleus sends signal to the norepinephrine release, and it goes to the pineal glands. Pineal gland, when activated, it release melatonin. So the suprachiasmatic nucleus is regulated by the environment, e.g. light. There are two stages of sleep: the rapid eye movement sleep and non-rapid eye movement sleep. Alcohols, benzodiazepines, and barbiturates are associated with decrease in rapid eye movement sleep and N3 sleep. Norepinephrine also decrease rapid eye movement sleep. Benzodiazepines are useful for night terror and sleepwalking by N3, decreasing N3 and rapid eye movement sleep. So in this two lines we haven't discussed about the non-rapid eye movement. Okay, and the main focus of our discussion is the benzodiazepines and the norepinephrine. So sleep stage, percentage of total sleep time in young adults. So awake. When we are awake, obviously the eyes are open, we are alert, active, mentally concentrated. If we do EEG on awake, then we have the major waveform with type which is beta. It is highest frequency and lowest amplitude. High frequency and lowest amplitude. So when we are awake but eyes are closed, the waveform will be alpha. Non-rapid eye movement when we asleep. And the first type of sleep we will have is the non-rapid eye movement, which is the light sleep. Obviously, when if we start from step one, we are awake, the eyes are open, then we are awake and close our eyes, then there would be light sleep, and the stage N1, which is 5% of our total sleep. And the EEG waveform which we will get is the theta wave. The stage 2 comes after it, and which is N2 and is 45% of total sleep. It is deeper sleep when bruxism, tooth tooth grinding sleep. It occurs, it means that in this sleep we will have tooth grinding phenomena, and we will get one waveform sleep spindles and K complexes. Okay, the complexes have made our this sleep stage complex, I think. So after it comes the stage N3, which is the 25% of sleep, and it is the deepest non-rapid eye movement sleep. Slow wave sleep, sleepwalking. It is so deepest that we aren't even aware of that we are walking in sleep or having a night terror or do bedwetting, V and flee in N3. So looks like an idiom, V and flee in N3. So sleepwalking and bedwetting is the main phenomena of this sleep, and tooth grinding is the main phenomena of N2. N2 mean tooth, and 3 mean V, bedwetting, and flee, sleepwalking. And we will get delta wave. It is the lowest frequency and highest amplitude. You can see that it is the highly opposite of when we are awake and eyes are open. Highest frequency, lowest amplitude, and lowest frequency, highest amplitude. It is the deepest sleep stage. After it, we will shift to rapid eye movement sleep, which is a 25% of our total sleep. It is a loss of motor neuron. Motor tone means we are not even capable of sleepwalking. We have no motor response, and there is loss of motor tone, increase brain oxygen use. Brain is now become activated more likely, and there is increased use of oxygen. Variable pulse, blood pressure, increase acetylcholine. Previously, we have discussed that acetylcholine is generated in the forebrain, so maybe forebrain is the more active. So, the rapid eye movement is when dreaming. When we are dreaming, when the main function which is going on is of brain, and we are dreaming, we may have nightmares. We and pencil clitoris tumescence. Maybe we have erection and clitoris tumescence occurs. May serve memory processing functions, extraocular movement due to activity of PPRF, which is paramedian pontine reticular formation activation, and conjugate gaze center occurs every 90 minutes and duration increase through the night. We get beta waves. We get beta waves changes in the older adults. When we get older, there is decrease in rapid eye movement. It means we don't see more dreams. Then there is decrease in N3 movement. There is less sleepwalking and less bedwetting as we get older. And there is increased sleep latency and increase early awakening. From here we can see that the older people are more likely to awake when there is early bedtime or early in the morning, sorry. Changes in depression, increase rapid eye movement, sleep time. When we are depressed, there is increased rapid eye movement, sleep time means we can see more bad dreams, decrease rapid eye movement latency, decrease and 3 repeated nighttime awakenings and early morning awakenings, terminal insomnia, and changes in necrolepsy. Necrolepsy mean when we sleep a lot. So, decrease rapid eye latency at night, beta, drink blood. Bats, bats drink blood. So, what does that mean? Bat drinks blood? What is it? Bats drink. I don't know. What does that mean? If you know, kindly uh, tell me in the comment section, please. So, what is next? This is our last page. Hypothalamus, very important structure. Hypothalamus. It maintains hemostasis by regulating thirst and water balance, controlling adenohypophysis anterior pituitary and neurohypophysis posterior pituitary. It releases hormones produced in the hypothalamus and regulating hunger, autonomic nervous system, temperature, sexual urges. Tan heads. Tan mean T mean thirst. A means adenohypophysis. N means neurohypophysis. H means hunger. A means autonomic nervous system. And T means temperature. S means sexual urges. Inputs. It receives input area not protected by the blood-brain. It is input areas. It receives input from areas which are not protected by the blood-brain barrier like OVLT, organum vasculosum. What was that? We may have to go somewhat previous. OVLT, yes, organum vasculosum lamina terminalis. Organum vasculosum lamina terminalis. You should keep it in mind for the next time. Oh, sorry. Yeah. Organum vasculosum lamina terminalis. Sensory changes in the osmolarity area postrema found in the dorsal medulla and respond to emetics. Yes, what is lateral nucleus? I think it is a part of hypothalamus. Yes, it's a part of hypothalamus. It controls hunger and is stimulated by ghrelin hormone, inhibited by leptin. So hunger, when ghrelin is increased, we are hunger, and when leptin is increased, we feel satiated or full. Lateral injury makes you lean. Okay. As lateral nucleus makes us feel hungry, so when it is damaged, we are not hungry anymore and we are not unable to, we are not stimulated to eat anymore, so we become lean. Destruction will lead to anorexia, failure to thrive in infants. So very easy thing in I think so. Ventromedial nucleus. It makes us feel satiated, that we are full and we are not hungry anymore and we should stop eating. It is stimulated by leptin. So ventromedial injury makes you very massive, as it makes us feel that we are becoming full and we should stop eating. And when it is damaged, we are not full anymore, we are not feeling that we have eating too much, so we keep eating and in result we become very massive. Destruction. Its destruction, as it is happened in the craniopharyngiomas, will lead to hyperphagia. Anterior nucleus, it is related to cooling parasympathetic, so it means that it makes us feel cool. So A and C, anterior cooling. A means anterior nucleus and cooling AC. It switch on our natural AC. Oh, wow. Posterior nucleus, heating. It makes us feel hot. Oh, wow. Hotspot. So heating controlled by the posterior nucleus. Hot spot. Pot means posterior. Heating mean hot means heating. It heats us. Suprachiasmatic nucleus is also a part of hypothalamus, so it is involved in circadian rhythm, as we discussed previously. Oh wow, we are interconnecting. We in the first lecture. See, in the first lecture we are interconnecting the lot of things. So it is involved in circadian rhythm. It is involved in our sleep. So circadian rhythm. Suprachiasmatic nucleus is a sun sensing nucleus. So as we discussed previously that it is triggered by it is driven by light. Correct. Supraoptic and paraventricular nuclei synthesize ADH and oxytocin. ADH is antidiuretic hormone and oxytocin is most likely a love hormone, I think. Sad box means supraoptic nucleus. It is related to ADH and paraventricular nucleus is related to oxytocin. So ADH and oxytocin are carried by the neurophycins, mean posterior pituitary, down with the axon to the posterior pituitary, where these hormones are stored and released when stimulation occurs. Preoptic nucleus, it is involved in thermoregulation, sexual behavior, and release growth hormone. Failure of GnRH producing neurons to migrate from olfactory pit, Kallmann syndrome. So what is producing GnRH? Obviously preoptic nucleus, and when it fails or when it damages and when it fails to migrate to the from the olfactory pit, this condition is called Kallmann syndrome. Keep it in mind. So thalamus, Thalamus, very important structure. What is it? It is major relay for all ascending sensory information except olfaction. All sensory information except olfaction will go through the thalamus. Keep it in mind. So it have a lot of nuclei. Oh my god, one, two, three, four, five. So the first one is the ventral posterolateral nucleus. Ventral. So it receive input from the spinothalamic. Spinothalamic, you can recognize it as it comes from the spinal cord to the thalamus. So it receives input from spinothalamic and dorsal column medial lemniscus. What does it sense or what does it receive? It receives vibration, it receives pain, it receives pressure, proprioception, conscious, light touch, and temperature. VPPPL. Ventral posterolateral nucleus. Destination. It is the primary somatosensory cortex in the parietal lobe. So, the second is the ventral posteromedial. It was ventral posterolateral. It is ventral posteromedial. It receives input from the trigeminal and the gustatory pathway. Gustatory means from our taste pathway. It sense face sensation and taste. Trigeminal is the sensory supply of face, so it receives face sensation. And gustatory is related to taste, so it senses taste. It is the primary somatosensory cortex, parietal lobe. So very pretty makeup goes on the face. It wasn't needed for it. You can remember it from this till now till that. So lateral geniculate nucleus. Lateral geniculate nucleus. So if there is lateral, there will be something medial too. So what is lateral geniculate nucleus? It receives input from cranial nerve to optic chiasm and optic tract. So it means it is related to vision. So it receives vision sensation. It is the primary visual cortex, which is obviously located in the occipital lobe. You know already. We don't need it. Okay, go. We don't need it. Medial geniculate nucleus. It receives input from the superior olive and inferior colliculus of tectum. So superior olive and inferior colliculus of tectum, it is related to hearing, so it receives hearing sensation. Hearing means it is primary auditory cortex, which is located in the temporal lobe. We know already. Medial mean music, lateral mean light. So ventral anterior and ventral lateral nuclei. It receives input from the basal ganglia and cerebellum. Basal ganglia and cerebellum, you know, it is related to motor, so it receives motor sensation. It is motor cortices, frontal lobe, Venus astronaut, Woe to Love movie. Okay, not bad. So here is the 10th page is completed. Thalamus nuclei, we can remember it again. First one is the ventral posterolateral, then ventral posteromedial, then lateral geniculate nucleus, then medial geniculate nucleus, then ventral anterior and ventral lateral nucleus. Okay. Oh my god, it was very exhausting. Yeah, exhausting but not difficult, and we will meet our target. Okay, I will see you in next video.